do nurses study? How do they study them? How do, I'm saying pronoun, how do you help people find those studies? And what do those studies look like? But we're going to have to do a little bit of a detour. And the history that Sharon gave was a very good introduction to that. I found this picture, and I don't know where it's from, but you'll notice, of course, that it's African-American nurses, and this is something of an anomaly historically. It's been primarily white women. So this influence of gender and class and race is really, I think, important to understand the current status of the field. And Sharon talked about sort of the characteristics of a profession, one of which has to do with this unique body of knowledge. And what is the unique body of knowledge that nurses have that entitles them to this claim to be experts in that field? And that has turned out to be kind of difficult to identify. There were, as she said, the predominant means of preparing nurses for the first century or so was in these hospital-based training programs. There have always been university programs, but they were generally a minority of nurses that went through that path. And there were not a lot of graduate programs in nursing. So there weren't opportunities for nurses to develop the skills of doing research. And there was a lot of talk about this concept of borrowed knowledge, that nurses were making use of biology, microbiology, anatomy, physiology, medicine, sociology, psychology, all this kind of stuff. And that's fine, that's interesting, that's appropriate, but is there something that is uniquely ours? So if we're going to be, especially as we're trying to then establish graduate programs in nursing, we have to have some science that we think we're going to teach people. So there was this real sort of complicated push to invent a field of nursing. Most of the early graduate training that nurses got was in something else, usually education or psychology or anthropology. So there was this need to sort of invent the science of nursing. Some very early doctoral programs in Columbia, NYU, Boston University had one of the early ones, which then later famously demolished by John Silver, but that's another story. The Public Health Service provided funds for some really important early graduate training to develop nurse scientists. And then starting in the 70s and 80s, there was this real explosion of doctoral programs in nursing, so that people could get trained as researchers, they could start doing the research, they could start training other researchers, and start to sort of outline this field of nursing science. So part of what I'm trying to convey to you is sort of both how recent this is and how much of a sort of effort it required to come up with this field. So 1986, the National Center for Nursing Research was established as part of the NIH. In 1993, that became its own separate institute. In 1970, there were 20 doctoral programs in nursing in the United States. About 2000, that was 78. In 2015, there's over 300. But those are not all PhD programs. A lot of those are DNP programs, Doctor of Nursing Practice, and a big chunk of those were master's programs that got sort of elevated up to DNP programs. So I don't know, I wasn't able to find a number for how many PhD programs there are. But certainly there's been a comparative explosion. And these journals, so Nursing Research, one of the oldest journals, established in 1952, Journal of Nursing Education, 1962, and then late 70s, early 80s, this explosion. Of course, now with online publications, there's zillions of them. But I don't know how many of you have nursing journal collections in your library, but it's really interesting to go back and look, especially if you've got them on the stacks, to go and look at the hard copy, because they just have this feeling like they were stapled together in someone's basement, you know. And they're really, you know, they're like so earnestly trying to invent this science. And I mean, it sounds like I'm mocking them, but I'm not. I'm in awe of the effort that they put into this thing. So there's that, the need to sort of invent this field. As Sharon also alluded, you know, we're a practice discipline, so nursing practice has always been sort of the center of people's attention. And going along with that, and especially sort of in the context of gender and class and all the rest of it, there's this sort of ambivalence about the status of science and about the status of theory, and the sense of like, well, is theory really important? Is it valuable? Is it real? No, it's just what those people in schools do. What's really important is what happens at the bedside, you know, that sort of tension. As I said, we've sort of entangled with other fields. It's very difficult to think about nursing practice disconnected from the practice of other disciplines, physicians, social workers, physical therapists, pharmacists. You know, we all sort of work together, and so what is the unique nursing piece? Nursing practice usually occurs in large institutions, whether it's hospitals or public health agencies or schools or whatever. So again, sort of what is the nursing practice separate from its institutional context? Then just as we were starting to really sort of get a hold of what is our unique field compared to everybody else, there's this push to sort of come back and be a team again, and we should all, you know, collaborate and be a professional practice, which is good. I mean, it's totally appropriate, but it also makes it complicated then to figure out what is our unique contribution to this team. To what extent can we share tasks? To what extent do we have to make claims for this is what only nurses can do? Very complicated. And then this notion of evidence-based practice, which I'll come back to at the end of, you know, what does that mean? Why are we doing it? What is the problem? Right? So, I don't know if they're looking at here, but it's very scientific. And you'll notice the hats, right? The hats were historically very important. We don't do this anymore. I think nursing is the most interesting profession in America, right? Sharon sort of described in some ways like what a big mess it is. So there's 6 different ways to get in, and there's 27 different organizations and all that. But it makes it really interesting if you're interested in studying professions. But also because we are at this intersection of all kinds of interesting things. So science and gender, technology, touch, you know, the tension between the hospitals and the community, all that kind of stuff. Like nurses are right in the middle of that. So I'm just going to say that. I'm not going to try to defend it, but that's right. And yet it's very difficult to define exactly what the nurse's work is, and that's partly because it's evolving historically. It's partly because it differs depending on where it is. You know, if you think about a nurse working in an intensive care unit, and a school nurse, and a nurse who's doing community outreach with homeless people, and a nurse educator, a nurse researcher, like how are they all doing the same job exactly? It's not exactly. So it makes a very interesting study, but it's not easy to evaluate or to teach or to figure out how to do that. So really, basically, if you think about the work that we do, we take care of patients, we take care of families, we take care of communities. And so a lot of the things that we do research on grow out of that work. How can we take care of patients better? How can we take care of families better? How can we take care of communities better? Thinking about what contributes to health, what contributes to illness. And there are huge debates going on right now, as you probably know. Historically, what we've focused on has been health care. Health care as contributing to health. Individual lifestyle behaviors, encouraging people to stop smoking, eat less salt, less fat, more fruits and vegetables, walk more, all the stuff that we know we're supposed to do that we don't do. Genetics, then this explosion with the Human Genome Project and so on, trying to figure out like how much of a difference genetics makes to them. In the past couple of decades, there's been, again, an explosion of knowledge about the influence of the social determinants of health. So these are things like income inequality, racism, neighborhood factors, where you go to school, all the things that are not health care, but that make a huge difference in health. And then random chance. There was a story that came out a few years ago. I wish I'd kept the headline, but if somebody had done this sort of meta-analysis of cancer, they were saying the biggest contributor to why people get cancer is random chance, which we don't ever want to tell people, right? Like, why did you get cancer? It just happened, right? But that's like a big piece of what happened. So you know, this is like, those are really different kinds of things if you think about, you know, researching health care, researching individual lifestyle things, researching genomics, researching how society is organized. I don't know how you research random shit. So what kinds of things do we look at? Historically, one of the things we've looked at is how do people cope with illness? How do they manage their illness? And especially if you think about people with chronic illnesses, right? They can't just go into the hospital, suspend their daily life, and then resume it when they come back. They have to live with this. They have to live with it, right? You come into the hospital with diabetes, you're going to go out with diabetes. Diabetes, asthma, arthritis, heart failure, all these kinds of things. This is mostly what we deal with in healthcare right now, is chronic illness and disability. So that means it has to be integrated into something. How do you navigate the system? Anybody who's tried to access the healthcare system recently knows what a complete disaster is. And I find it hard to do, and I've got a PhD in this. So how do we help people who are caring for their family members? How do we help people care for themselves? What does it feel like to be someone with this illness? What's that like for you? What is health? We spend mostly what we talk about is illness. We talk about health care, but really what we do is illness care mostly. But if we're trying to get to health eventually, you might want to think about what that is. What is the quality of life? Right? Do we want to live to be 100, but the last 30 years are, miserable? No, probably not. We want to have good quality. And we have to figure out about death and dying. I should probably put birth on there. I tend to think of the end, but we're so involved in birth. How do we do birth, right? But death and dying, we've got, I think nurses have a little bit better track record in this than compared to physicians who have always sort of like been like, oh, death is the enemy. We know that death is not the enemy, death is what happens, but we can make that better and worse. So, what kinds of research studies are there? Lots. So, trying to think about how to divide this up in a way that will be at all coherent for you. I was thinking about different ways of dividing. So you can think about it in terms of sort of design, goal, what we're trying to get at, methodology, rigor, underlying philosophy. So we're going to run through those really fast. One way to really sort of simplify different kinds of studies is to think about there's descriptive studies, there's intervention studies, there's evaluation. Descriptive studies are all the studies that just describe the world as it is. Right? Intervention studies and experimental studies, you're doing something to people. Experimental and intervention are sort of linked. Experimental I think of in terms of like a laboratory situation. I bring a bunch of librarians in and I do something and then we see if it works. Versus a clinical intervention. But they're the same idea. You're doing something to somebody and then you want to see if it made a difference. Evaluation studies, I pulled out as separate. They're a little bit of both. You're just trying to sort of figure out how the system works. Right? So, descriptive studies. What's going on with X? Does X go with Y? Is there a correlation there? What's it feel like to be X? Right? All of the, most of the qualitative studies, not all, but most of the qualitative studies are descriptive studies. What's it like to be? Who comes? So I'm thinking of the policy stuff because that's what I mostly do. So who comes to the emergency room and why do they come? Why do they have a primary care physician? Does it make any difference that they have a primary care physician? Do they have insurance? Is it weekend? Like, why do people come to the ER? We have this huge number of people coming to the ER that don't really have an emergency. We want to decrease that. First, we have to find out what's going on. Certain people come to the ER and they don't really have such a great time. Certain populations, for example, injection drug users, homeless people, traditionally have a really terrible time. So, what's that like? What do people know about X? What's the status of nurses' knowledge about injection drug users, or homeless people, or the resources in the community, These are all, we're just finding out what's going on. Intervention studies, as I said, we do something, we want to see if it worked. This compared to what? Did it work? How well did it work? How long did it work? For whom did it work? If we find out that nurses in the ER don't really have that much knowledge about community resources for injection drug users, syringe exchange programs, we could do a little education program, and then we could find out, does that increase their knowledge or not? We could do a screening tool, right? Find out who benefits or doesn't benefit from screening people for hepatitis vaccination. And then, as I said, I sort of pulled out program evaluation or health services research as a separate category, because I'm interested in that, but also because it's a little bit of both of those sort of descriptive and intervention kind of things. We're trying to find out, usually does a program work, does a system level change, does it make a difference? We might use quantitative, we might use qualitative, we might use both. if, again, thinking about ERs, if we found people that come to the ER that didn't have a primary care provider, and we wanted to change that, we wanted to get people hooked up with primary care providers by referring them when they're in the visit, we would do an evaluation of the program to find out, did that make a difference to the rate at which they return. If we were trying to encourage people who homeless people not come into the ER for their primary care because they don't have a good experience and they're not really what the ER is for, and we want to build relationships with them so that they'll go to someplace else. Again, we were trying to find out, did it make a difference? What was that like? How did it work or not work? Right? Those are the sort of the main big families of research, descriptive, intervention, program evaluation, and then there's a sort of bunch of miscellaneous kinds of things. Community-based participatory research or action research is research that involves the people that you're studying. So instead of me as a researcher saying, I'm going to do this to you for your own good, or because I'm curious, I would involve you. So if we were doing a project on, librarians learning about nursing research, you and I together would design the study, and we would take action, and we would, that's called action research. Feminist research, critical theory research, these are kinds of designs that more explicitly grapple with issues of power, gender, inequality. I think all research is political, but this is more explicitly political in the sense of we're saying, my goal here is to, improve the status of women. My goal here is to make the world safer for, LGBT patients or whatever. There's lots of different kinds of research, so these are sort of the other. The other way to think about dividing up research is in terms of what kind of research report it is, what kind of source it is. Think about it in terms of levels. So there's a lot of things that are sort of single study reports. So whether it's a pilot study or a big study or whatever, but it's a single study. And those could be more or less rigorous, more or less realistic, but single study. And this is really, from some of this is I'm telling you, but I'll also say it's really important that you tell your students or whoever you're working with to sort of help them distinguish these, because this is the kind of thing that in my experience students have a really hard time with, sort of figuring out what is this article reporting on, right? Is it a reporting of a single study, or is it a literature review or whatever? So single study. Then if you put a whole bunch of studies together into a program of research, that's a lot more powerful, right? Any one study can give you whatever it gives you. A program of research, a series of studies, sometimes by a single team, sometimes by a group of people in different places, you have more confidence that this is something that's really going on. A more formal version of that would be a meta-synthesis or a meta-analysis, some kind of review that sort of tries to take everything that we know about a certain subject at a given point in time and pull it together and say, what do we think is going on here? Another way to divide it up is to think about it in terms of methodologies, and methodologies sort of more or less go with worldviews. So quantitative is sort of a typical category, sometimes also linked with a sort of empiricist worldview. Qualitative, interpretive worldview, and then just other things. Right? So this is a chart that I made up for students a few years ago. It's wildly oversimplified, but as a heuristic. So empiricists, like, they're interested in the facts, right? What's really going on? The goal is to find the truth, right? And usually they do that by counting things. Not always, but that's usually what it is, okay? And then what they do with what they've counted is they analyze the statistics. Correlation, ultimately you like to find causation, you're trying to eliminate chance, right? This is how they go. Interpretive people, they're not interested in facts, they're interested in experience. Right? What does it feel like to be you? What does it feel like to be in this situation? And so their data is stories that people tell them. Sometimes observations. So I go to a place and I watch you, and you tell me about it, we put these together, and the goal of that then is understanding. trying to understand what it's like either to be you or to be in this situation. How does this work? This is what anthropologists do. This is what sociologists do. And then there's this other category that I call critical or feminist or structural or whatever. And their view of reality is it's political. Right? And our goal there is to change the world, try to make the world a better place. So they might use any of those. They might count things, they might hear stories, they might do observations. And then what they do with that data is they analyze the power relationships. Okay? Simplistic, but it is. It breaks down because, of course, everybody wants to change the world. Everyone wants to rule the world. It's the kind of tears for fears. Everybody has to interpret. Everybody's political. Anthropologists sometimes count things. You know, it's messy. But those kind of broad families are okay. Another framework that you probably should know about, just because a lot of people will come in with it and ask you about, is something called PICO. And a lot of people like it. It's just a way to frame sort of your research question. Right? Because students come in, they have this sort of amorphous ideas, and then we're trying to organize that. So PICO is an acronym. P is a population. Who are you talking about? What's the problem? What are we looking at? Homeless people coming into the ER. Intervention is what we do. Comparison is the intervention compared to what? Individual care, something else. And then outcome is how are you going to know if it made a difference? Right? So this is a framework for an intervention study, right? And trying to figure out how can you organize that. And then you can organize your literature search to find out what do we know about this art? What do we know about homeless people coming into the ER? And something was done compared to what? How do you find these studies? This is a friend of mine who used to say this to students all the time. I don't know if you ever have this experience with people coming in and saying, I couldn't find any. Because you do such a good job of teaching them how to find things. There's nothing there. Yeah. All right, so we started talking about this already in terms of there's primary sources, there's secondary sources. People have a hard time, students in my experience have a hard time distinguishing those. You guys are really good at distinguishing those, I'm sure. Secondary sources, can you see that all right? Secondary sources is a broad category, right? It could be a literature review that is a narrative literature review where they just sort of walk through a bunch of studies. Could be a very organized, structured, systematic thing with a lot of algorithms. And, meta-analysis, meta-synthesis is extremely structured, and they generally pool the data, try to make it all as if it were one big study. Just look at the net effect of all that. In nursing and probably a bunch of other fields, there are a lot of articles that are in the genre of advice to clinicians, right? So they're not necessarily designed as primarily as research articles. They're making use of research, but their audience is the busy clinician and what do you need to know, update about, whatever. Which is a completely fine genre, but it's a sort of more popular oriented kind of theory articles, editorials. Journal articles is going to be probably the largest source for a lot of these kinds of things. It's kind of a messy world out there. Peer-reviewed is not really, in my experience, very helpful as far as distinguishing the better and the worse journals. I don't know. Maybe Hillary can tell you more about how to distinguish the better one. I mean, I can look at an individual one and say, yes, that's good or bad, but that's about it. So there's journal, but there are journals. There are government sites which have lots and lots of data, and students often, in my experience, don't necessarily think of those or know about those. I'm going to show a few of those, but the CDC has massive quantities of data. In Massachusetts, there's something called BASCHIP, which again has sort of state-level data, massive amounts of stuff, really interesting. There's a lot of foundations and think tanks out there. which I often send students to because I sort of feel like if somebody else has already analyzed this situation for you, you should make use of them. They have to be taken with a grain of salt. They have to be, the better and worse. But Kaiser Family Foundation, Robert Wood Johnson Foundation, Commonwealth Fund, there's lots and lots of great think tanks out there that have analyzed this data. And it's very good quality, a lot of times. It used to be called the gray literature. And I don't know what, now that it's on the internet, it's not so gray. But, and then the Cochrane database is this, this international organization that does these sort of evidence syntheses where they try to find out all the evidence that's out there, synthesize it, say, here's what we know, and then here's a recommendation about it. We're going to come back to that a little bit. How do you find these studies? Sinal, are you guys familiar with that? Okay. Cumulative index of nursing knowledge. I don't know if this is true. This is what I've always been told. Sinal and PubMed are not exactly parallel terms, right? Because Sinal is a database, and you search through it with Dept, but PubMed is the search engine, right?
They're different databases.
No, but I mean, this is
PubMed is the search engine itself and the database.
And both.
The database that you're searching is Medline.
It's Medline.
Medline Plus. Right.
But Sinal is the database, right?
Sinal is the database. It's a platform.
Not everybody.
Yeah.
In my experience, there's a huge amount of overlap, and the main differences are sort of how they're organized. If all you want is nursing articles, you should go to Sinal, because that's mostly what they have. And PubMed has a lot of other stuff. There's, there's a lot of stuff that is of interest to nurses that doesn't necessarily show up. Then there's other databases, which you probably also know, PsycInfo, Eric. I like Web of Science. I think it's a cool thing to play with. It doesn't have a lot of nursing journals. It's not a very good source for nursing journal articles. But if you just want to play with stuff, I like it a lot. I like their cited by picture. Google, in my experience, is a really good place to do a quick and dirty search, right? You just want to bang in there, find something. And also, you can, if you find scholarly articles, it has this pretty nice, cited by feature. It's also probably, in my experience, the best way to find a lot of these sort of policy sites, these foundations and think tanks and so on that don't show up in scholarly literature. You also get a lot of junk and a lot of weird stuff and a lot of stuff that students get swamped by and they don't know how to sift through it. So I can find stuff quickly, you can find stuff quickly, but to send students there, they often never come back. So you probably know what these look like already. So this is a Google search. This is this is their little cited by thing that I like so much. Because then, and then you can just it just opens up all the stuff right. Kaiser Family Foundation. I love the information they have. A couple years ago, they changed their user interface, whatever, the design of the website, and I hate the new design. Can't find anything anymore, but that's it. Commonwealth Fund, these are just examples. WHO has tons and tons of data, and they have, country reports and just all kinds of stuff. So if people are looking at international issues, they are really, really rich. If you're in Massachusetts, this has lots of data. CDC has lots and lots of data. And this is the Cochrane Library, the Cochrane database. This is what its sort of public face looks like. If you go in through our library, it looks here. I don't know what access we have. All right, so evidence-based practice. What is it and why are people so upset about it? So the first of these, I don't know if you can read like everything else that's contested. The first of these from David Sackett is the conscientious use of current best evidence in making decisions about patient care. This is sort of probably the most common definition. What that means, sort of translated into practice, is it's a structured, systematic approach to gathering, sifting, and synthesizing the available evidence, right? So there's a lot of research out there trying to figure out how to pull it together, make sense of it, sift through it, sort it. What do we think we know today? Right? Less generously, it is sometimes seems like a fanatical obsession with RCTs and meta-analysis is that would answer every important question. Some days I feel about evidence-based practice to what Gandhi supposedly said about Western civilization, which is wouldn't that be a good idea? Right? Because the scary thing about evidence-based practice, for those of you not in the healthcare field, is that's not what we do right now. Sorry to tell you that. So anyway, so this is the evidence-based pyramid, the evidence pyramid that this sort of thing is based on. So, have you seen this before? You know this?
Yeah.
Okay.
No.
So this is just what experts think, which is sort of nothing. And then like all regular studies. These are like the single studies. And then there's this, gap, and then there's this notion of sort of critical appraisal, like sifting through this. Right? This is a study, who knows what it means, and this is putting them together into everything. And then so a systematic review is the top of the pyramid, right? That's all the best. So what's wrong with that? So anyway, why are we doing it? Because we know that practice lags behind research. We know that there's a lot of stuff that people are still doing, even though we no longer think it's best or most effective. One of the biggest reasons we do this, that we want to do this, is just that there's so much research now that people can't reasonably be expected to follow it, right? Once upon a time, you could probably subscribe to a couple of the big journals, read them periodically, and you would sort of have a feel for what's going on. Nobody can do that anymore. So we sort of need some more organized way to make sense of this. There's a lot of research out there, there's a lot of articles out there, a lot of journals out there, wildly varying quality. Somebody has to sift through it. And then as we're moving toward a healthcare system that is more about big systems, not lone cowboy practitioners out there, we need to figure out a way to decide, like, what are we all going to do? Not leave it up to individuals. So why is this, what's the problem with this? Well, the biggest problem is just that we don't have a lot of evidence about most of what we do. We have tradition, we have what people think, we have experience, we have what, but we don't have really, we certainly don't have the top of the pyramid for a lot of time. And partly that's because there are a lot of things that don't fit into that framework, right? You can't randomize a lot of things. You can randomize some things. But you can't do that for everything. You can't count everything, you can't standardize everything. And that framework sort of skews you toward things that can be randomized to things that can be counted to things that can be standardized. So for example, my example is always thinking about psychotherapy. So if you want to find out, like, what is a good therapist, right? It depends a lot on the individual person. And what we can study in a randomized clinical trial is something that's very standardized. So we can get evidence about that. Someone who is just a good listener and good with making insightful, warmly supportive comments, that we can't study very well. So there's that problem. And just this notion that randomized clinical trials are good for some things, but not for everything. So, what am I doing on time? All right. I forget my time. Okay. So, 10 minutes? Okay, good. So I'm going to just show you a couple of different kinds of studies that are really different to give you a sense of what they look like. So this one is this is Linda Aiken, one of Linda Aiken's articles. Linda Aiken, there's a whole group of them. And this is a massive study. So 200,000 patients, 10,000 nurses, 170 hospitals in Pennsylvania. This is one of the first really gigantic studies, extremely well designed, that looked at this issue of educational preparation. So what they're trying to find out is what makes a difference in terms of surgical patients' outcomes, right? So this is not community health, touchy-feely, anything. This is like really very med-surg. Everybody that had surgery, how many of them died within 30 days? How many of them had complications that they shouldn't have had and then died? Those are the outcome measures. And they looked at this issue of nurse education level, nurse staffing, how many patients were nurses on average taken care of, what was the work environment, and what were the years of experience. And the things that are important to keep in mind here is that the unit of analysis here was the hospital. So they were comparing hospitals to hospitals, not individual nurses, because trying to figure out like what difference any individual nurse made to any individual patient is really hard to do. So the unit of analysis is the hospital, so proportion of nurses with a bachelor's degree or higher, etc. And what they found was that education made a difference. Nurses that had, hospitals that had a higher proportion of nurses with a bachelor's degree or higher had lower 30-day mortality and lower complication rates. Work environment made a difference, staffing made a difference. Years of experience did not make a difference. So this was hugely controversial because it really said, okay, those nurses that went to diploma schools, those nurses that are going to community colleges are not doing as good a job on average overall as nurses with a bachelor's. The other thing that's interesting about this study for me is we don't know why that is, right? It's a black box. We have the input and we have the output, but we don't know what's going on. We don't know why having a higher proportion of bachelors, et cetera, makes a difference. The staffing, you can sort of figure. The work environment, you can sort of figure. But how does education make a difference? So there's a whole bunch of data that comes out, studies that come out of this. A completely different kind of study. This is a really small qualitative study from Canada. They interviewed 12 nurses at a clinic in Halifax. And they asked them, how do you take care of patients that are LGBTQ? How does that go? What do you think about it? And what most of the nurses said was stuff like this. Well, I treat everyone as a unique individual. They were very anxious not to be bigoted, to not discriminate against me. They didn't want to say the wrong thing. So they basically, we're just going to ignore that altogether, unless it comes up in terms of very specific sort of sexual health issues. But there were a few nurses that said, well, there are some differences here, right? There are ways that this is important to people's lives that is not just about sexual health or sexual rights. And so they do a nice job, I think, of sort of describing this problem that is an inability to sort of figure out how to recognize this difference. And then some clues about how to do it differently. So the previous study was, 10,000 nurses. This is 12. Maybe they were just 12 weirdos in Halifax. But when I read this report, I think, yeah, this sounds really familiar to me. This sounds like the way nurses talk. And this sounds like the kind of problem that nurses would have, which is this notion of, well, everybody's unique, I know. And then finally, here's a review article that was done a few years ago where they looked at sort of the research about men who have sex with men, particularly black men who have sex with men, in terms of HIV prevention. And they came at it from using the lens of what they call integrative racism. So trying to think about racism and the effect on this situation, and also religious oppression, cultural assets, and religious assets. So using that framework to evaluate the studies that are out there. And what they found is there weren't that many studies. The ones that there were didn't have a lot of black participants, and that very few of these studies sort of theorized very clearly how does racism and these other elements fit into the problem of men who have sex with women and HIV prevention. So really sort of like identifying a gap in the literature in a way that I think is very interesting. So these were just really three completely different kinds of articles that I want to just throw out there to show you the breadth